He's 75 years old male. He has coronarity with 5 coronary stents, diabetes. In January 2016, for epigastric pain and weight loss, patient underwent a CT scan that showed a pancreatic mass in the body with a liver lesion. And USFNA were performed 2 times, but was no conclusive. And the patient is here today for new US evaluation with FNA.
We've got this very unusual case, much more exciting than pseudocyst drainage. It's how to do an FNA. And of course, failed 2 FNAs, and now I'm stuck with doing this case. So the plan is to do the FNA, and unfortunately, we don't have a cytopathologist in the room. So it's a perfect scenario. I'll do the FNA, then I'll fly out of the country tomorrow before the results. So here we have, if you've got the EUS picture in your screen, I'm using the new, I was going to say Areola, I will not say Ariata. Ariata. The Ariata machine by Hitachi, beautiful, and Adam and I have been trying to get used to it.
We learned it for the next 5 minutes.
Yes, and we would like to insist that nobody asks us about elastography or contrast.
It's always also the first time.
So do you see the lesion in front of you?
Hey, Ryan, just a question. When you have a lesion that's like, it's been biopsied multiple times, what comes to mind as a differential diagnosis? Like that obvious mass
Yes.
that when you biopsy 100 times always comes back negative.
Right.
What comes to mind?
So the few things are, well, could it be a benign lesion like a pseudotumor from chronic pancreatitis or pancreatitis? It could be a serous cyst adenoma, which is, comes back negative all the time. So these are the things which make you wonder whether it's a highly necrotic lesion.
And we see necrosis.
And that can happen. And I've had cases where I've done biopsy after biopsy and it's been negative. I've bent needles trying to get in, and finally it's been proved on laparoscopy to be a tumor. So some of these inflammatory masses can result in negative FNAs. So
it's calcified. Too.
Yeah, and it's calcified, exactly. Well done, Anand. You've done a few of these, have you? Mm-hmm. So you can see...
So there are sharp margins, and we would be interested if there is perfused tissue, yes or no.
We were not supposed to talk about.
Yeah.
Oh, God. Christoph is is moderating, is he? Christoph, I will not change the settings. Don't ask me to change the settings.
We can do elastography.
I wouldn't do it, but we have been talking 2 times. There has been negative biopsy, and Anand told us what will be the criteria to change our strategy.
Right.
So it would be worthwhile to see small vessels to put into that area also the needle.
Can we increase the Doppler to the fine...
I'm going with Christoph. I think one of the roles in these 2 previous negative cases, I think maybe there is a big role for elastography and contrast enhancement, mainly with that device, because it's not only that you can increase your capability to determine if it's malignant or not, but also elasto and contrast enhancement can be very nice to try to target some specific areas inside of the lesion. Yeah. So maybe the role, whenever you need to have a positive diagnosis, is to use elasto as a guide FNA to the better place, and also use the contrast enhancement with that regard.
Yeah.
I'm wondering if this isn't a gist coming off the wall there. If this was just on the wall, it would look like a gist. Or a leiomyoma or something.
So we'll use contrast. Eh? So what I understood from that discussion is that you'd like us to do contrast, yes?
We would love to see viable tissue, to see where to put the needle.
Okay, so let's start. We'll
we need to picture it, right?
Okay.
Yeah.
I'm starting the injection now.
This is a big problem, and this should be solved, because we have a technology which is the contrast with the hypo-enhanced sign as a positive predictive value for adenocarcinoma of 96%.
There is some.
And here there is some probably. And we don't use this for the decision in case of inconclusive biopsy.
Yes.
I don't understand. We need to have a consensus on this, and to not a consensus just with the endosonographer, but consensus with the gastro, the endoscopist, and the oncologist, because it's impossible to in the future with this kind of high positive predictive value to continue to try to obtain biopsy. And when after 4 months, the patient has a liver metastasis and so on and so on. I think it's we need to do something, to organize something, consensus for the use of the contrast in case of inconclusive biopsy.
So you're completely right, Mark. The only problem is to convince oncologists to treat a patient without a cell. But maybe we need to find a way how to do it.
They treat patients with positive PET. And you know that the positive PET, you have a 25% of false positive or false negative. Yeah. We don't have this with the SonoView.
And they also have a large double standard with pancreatic cancer. They'll let people go for a Whipple with no diagnosis, but they won't give chemotherapy for palliative treatment. Unless they have tissue.
Fully agree.
Yeah.
Okay. I think there is very few enhancements.
Right.
But
we can do elasto.
Yeah? Okay. This is easy.
Well,
yes.
On my vast experience with elasto, blue is bad.
And not only, not always.
Oh, not always. Okay.
Because sometimes you have a nodule of autoimmune pancreatitis, which is also very hard, but the nodule has an hyper-enhancement with SonoView. Huh?
Yeah. Here maybe it's necrosis that you can see with the elastography. It helps.
Okay.
So we're going to do the FNA. I'm using a 20-gauge needle. Okay.
20 seconds. Just let us think about what would be if we have how to say a negative result. What would we do afterwards? And if we have a positive result of a ductal adenocarcinoma, so would we change any strategy if that result would be negative right now? Would we go for surgery?
Yeah.
Let's have a pre-test probability. What to do with a negative result?
I will be in Malaysia. I wouldn't know. No, but yeah, that's a good question. I have done, and all of us have done, 3 to 4 FNAs which have been negative, and I've finally resulted in laparoscopic evaluation with biopsy. So that would be a cause, because really I don't think it's fair on the patient to keep bringing this patient back over and over and over again to do FNAs and it being negative. So I think...
but this patient has a liver lesion.
Yeah.
What about the option to make just a standard biopsy of the liver solid lesion, but ultrasound guided?
Yes.
I mean, a transabdominal ultrasound guided.
That's right.
Maybe that'd be an additional option if this is negative again?
That's right. Then laparoscopy, I think.
But we can try in the US. We can try in the US to do a...
Sorry?
The liver lesions are not so big.
Not so big, yeah.
No.
But we've seen something that maybe we can puncture in the liver.
Yeah. But you know what? We're going to get the diagnosis, though. We are going to get it today.
Okay. Please.
Okay.
Proceed.
So we're going to go into the lesion. All right. It's quite a hard lesion, but we're in now. And Cassandra's going to pull out and push back in the stylet. And then as I pull forwards and backwards, she's going to slowly pull the needle back. The stylet back, I'm sorry. So I'm just going back and forth. And it is quite a hard lesion. So what we're trying to do is create a suction between the area where in the needle and the stylet. So I'm hoping we're going to get some tissue as she's slowly pulling back. Yep, keep pulling back. And I'll just make it a bit...
Just so people know, when you measure the amount of suction you get with the slow pull, it's 0.
It's what?
It's been measured. It's 0. It's been measured. There's a paper coming out, or it hasn't been published, or if it's not out already, where they measure the actual amount of suction you get with the slow pull.
Yes.
And they did a slow pull, slow pull, and a fast slow pull, and they were both 0.
Thank you, Anand.
Plus or minus 0.
I think Takao had a paper on that as well, looking at this.
That was his group. That was his group.
Yes.
Well, he was on the paper anyway.
Yeah. I think it's kind of fun, though, don't you think?
The reason the slow pull works is because it takes so long to pull out the stylet that people sample for longer.
Yeah, we can take it out. Yeah. All right, so we're kind of done now. We're gonna just pull out. Yeah, take out.
Pull it
come out. I'm just gonna just.
So how many passes would you like to perform in this case, knowing that there's 2 previous negative FNA?
Yeah, well, that's why I think a pathologist in the room would be ideal in this case, because I wouldn't leave here till it's positive, you know. So I'm just turning my direction a bit to see whether I can get a different area, and that's it. So we'll just do this a few more times.
Want to show them the liver?
All right. We'll just show you the liver, and I like your opinions, Christoph and Anand. So you got the liver. This is the area in question.
The liver lesion was not punctured
Not
because
punctured,
the
yeah.
patient
Yeah.
was on aspirin
Right.
at this
But-
time, and
But
So-
looking at this lesion, I'm not too impressed.
If it's focal, if it's geographic, something that is more diffuse, we should puncture it.
What do you think? Okay, let's look at the second. That says
What we see in the near capsule area, multiple hyperechoic
you have
spots,
enough.
which are typical
nothing?
for cholangiofibroma. So it's an eye catcher of those very tiny lesions. So at least the other lesions look pretty
benign.
healthy.
Yeah.
And in that biliary malformation,
Okay.
I didn't see really
Yeah.
something suspicious
You
at
should
this
do a second
moment.
puncture, huh?
So
Yeah.
it could
Because there
be
is no tissue.
secondary to
With the
that
aspiration, maybe
malformation.
it's better.
Okay.
Maybe we should show them the lymph nodes.
All right. I think So we're biopsying the left lobe.
Okay.
Just to, and we changed the needles. So we're using a 25 gauge needle into the left lobe. You can remove it. Just remove it and remove
Brian,
it.
sorry to bring this up, but if you would have used contrast, it would have been really nice in the late phase. So we're looking after, let's say, 2 minutes of the during the contrast
Right.
on the left liver lobe. That's really nice because the metastatic lesions, they have washout.
Okay.
You
We
can clearly see where to target your
Right.
your FNA.
okay. Well, we could do that after it. Kind of defeats the purpose then, but we can.
You are ready to? Not yet. Okay.
Yeah.
Is it stiff tissue, what you are biopsying? What is your feeling?
Soft. It feels soft. Why do I have a grimace on my face? Or yeah, it's just it feels softer, Anand. Yeah. All right.
Okay. Good.
So what we did was on the first pass we used the slow pull technique, and surprise, surprise, we got no tissue. So then we went back and did it again with suction, and we got quite a bit of
This is
tissue.
nice.
And we've also got some tissue from the liver.
No.
Oh, we don't. Oh, we do. Well, we'll keep trying. You want to? Shall we do contrast on this?
Yeah, we need another puncture because we don't have much material.
Okay.
Okay. You should do another puncture. Yes.
Okay.
Yeah.